We are going to study the extrahepatic cholelithiasis. Extrahepatic cholelithiasis is divided into primary and secondary calculi. Primary calculi refer to those formed in bile ducts and are mainly brown pigmental calculi. Secondary calculi are gallstones discharged into the common bile duct and are mainly cholesterol stones or black pigment stones. Calculi left in bile ducts mainly cause the following pathophysiological changes: acute and chronic cholangitis. When the cholestasis occur as a result of calculi, infection is liable. General infection: after obstruction of the biliary tract, the infected bile enters the blood circulation, leading to toxemia or even sepsis. Hepatic lesion: the complicating infection of the obstruction may cause the hepatocellular damage, resulting in biliary hepatopistema and biliary cirrhosis. Calculi incarcerated in the ampulla of the common bile duct may cause the biliary pancreatitis. The clinical manifestations of extrahepatic cholelithiasis mainly depends on infection and obstruction. In general, there is no symptom. However, when bile ducts are obstructed by calculi, causing an infection, the typical clinical manifestations are Charcot tirade, that is abdominal pain, shivering and hyperpyrexia, and jaundice. In general, the abdominal pain occurs as paroxysmal colic below the xiphoid or in the right upper quadrant and may radiate to the right shoulders, accompanied by nausea and emesis. About 2/3 patients may suffer shivering and hyperpyrexia in the course, generally present as remittent fever, and the temperature of some patients may reach 39-40. Jaundice may occur immediately after obstruction of bile ducts, and its severity, occurrence, and duration depends on such factors as obstruction degree, complicating infection, or whether the gallbladder is involved. In the case of such jaundice, the urine color becomes darker, the stool color becomes lighter, and the skin may be itchy. The obstructive jaundice caused by gallstones is generally intermittent and fluctuating. During diagnosis, ultrasonography is generally preferred and a definite diagnosis can be made according to the health history, clinical manifestations, that is Charcot triad, lab tests and imageological diagnosis. As for treatment, extrahepatic cholelithiasis is still mainly treated through operations at this stage. Principles: clear calculi at the earliest time possible, eliminate the lesion focus, solve the stricture and obstruction, clear and drain the ducts. The common surgical methods include laparoscopic common bile duct exploration and T-tube drainage. 1. The T-tube shall be generally removed 14 days after the operation. 2. Prior to removing the tube, press the tube for testing, and carry out the cholangiography. 3. In the case of residual stones, carry out the T-tube sinus tract fiber choledocoscopy 6-8 weeks after the operation. If it fails, another operation shall be carried out. Choledocygenostomy. The indications include 1 diameter of common bile duct 2.0 centimeters, inflammation and stricture at the lower end, fibrous stenosis of Oddi sphincter or stenosing duodenal papillitis. 2. Silt-like cholelithiasis difficult for complete removal in operation. The common operations include Rui cholangiogynostomy, jejunal interposition cholidocodiodinostomy. Duodenoscopic Oddi sphincter lithotomy. Of course, there are some emerging operation methods, such as minimally invasive cholelithiasis, and good curative effects can be achieved if the indications are properly understood. So much for extrahepatic cholelithiasis. Next, we are going to study the intrahepatic cholelithiasis. The etiology of intrahepatic cholelithiasis is complicated, but related to factors like intrahepatic infection, cholestasis, biliary tract ascariasis, etc. Most intrahepatic cholelithiasis is brown pigmental stones with bacteria. When intrahepatic cholelithiasis is complicated with extrahepatic cholelithiasis, its clinical manifestations are similar to those of extrahepatic cholelithiasis. For intrahepatic cholelithiasis not complicated with extrahepatic cholelithiasis, the patient may be asymptomatic and only feel a swelling pain in the chest and the back for years. In the case of obstruction and secondary infection, shivering or hyperpyrexia may occur, and even the manifestations of the acute obstructive and suppurative cholangitis. Unless the bile ducts on both sides are obstructed or the biliary cirrhosis is at the advanced stage, intrahepatic cholelithiasis is generally free of apparent jaundice. Complications of intrahepatic cholelithiasis may cause biliary hepatopistema, which may break the diaphragm and then puncture the diaphragm muscle in the lung to form a cholangiobronchial fistula. And the patient may cough out yellow and bitter bile-like sputum. In the case of biliary cirrhosis at the advanced stage, the portal hypertension may be caused. For patients with a long history of disease and symptoms such as frequent occurrence of cholangitis recently accompanied by abdominal pain and fever that is hard to control, weight loss, etc., especially patients older than 50, the possibility of complicating hepatic cholangiocarcinoma shall be considered. The main manifestations are asymmetrical hepatomegaly and tenderness and percussion pain in the hepatic region. In the case of complicating infection and complications, the corresponding signs will occur. The imagiological diagnosis is helpful for diagnosis and differential diagnosis. The B ultrasonography and the PTC examination can display the distribution of intrahepatic cholelithiasis and the stenosis and dilation conditions of hepatic ducts, and are significant to the diagnosis and guiding the treatment. In general, asymptomatic patients of cholelithiasis require no treatment, and only need periodical observations and checkups. Patients repeatedly having clinical symptoms shall be operated, and in principle, calculi shall be completely cleared at the earliest time possible, the biliary stricture and obstruction conditions shall be removed. The lesion focuses at calculous sites and infections shall be cleared, and free drainage of the bile shall be recovered and established, to prevent the reoccurrence of calculi. The common surgical methods include: the CBDE is the fundamental method, and efforts shall be made to incise a narrow position to remove calculi directly or with the support of intraoperative choledocoscopy, until all calculi are cleared. The cholelithiasis cannot be used as an alternative method for the treatment of biliary stricture and lesion focus of calculus. When the Oddi sphincter is still functional, practicing the cholelithiasis shall be avoided. The Roux-y cholangiogynostomy is often used in operations. Hepatectomy. This procedure is to resect the part of the liver with pathological changes, including the lesion focuses of calculus and infection and strictured bile ducts unable to be incised. Remove the recurrent sites of calculi and prevent the canceration of diseased hepatic segment and hepatic lobe, and is a positive approach for the treatment of intrahepatic cholelithiasis. The intraoperative auxiliary measures such as intraoperative cholangiography and ultrasonography can help to determine the quantity and position of stones. The choledocoscopy may be used for intraoperative diagnosis, lithotomy and lithotripsy. To sum up, calculi are formed because of the lithogenic bile, but the key lies in keeping the smooth drainage of the bile. Therefore, patients should eat regularly, take the B ultrasonography periodically to make clear the compensatory enlargement changes of intra and extrahepatic biliary tracts, and if necessary, take some cholegard to promote the bile discharge, which may be conducive to the prevention of calculus. After the partial cholecystectomy, some patients have calculi reoccurred in the common bile duct. This is because of the sphincter of Oddi dysfunction below the common bile duct, or because of some small gallstones dropped into the common bile duct, which present no symptoms for the time being but grow with the time passing by until being discovered. There is no need to be nervous. Even these stones occur, they can be removed through the endoscope as long as they are discovered early. That is all for cholelithiasis. Thank you for coming to the class. See you.